retina. So let's just briefly understand the history of FFA. So it was way back in 1871 when Bayer he synthesized sodium fluorescein, and Alvis in 1959 there was the first report of a fluorescein angiogram in human beings. And then we had Maclean and Momini in 1960 who described fluorescein angiography. So coming to what is the principle of a fundus fluorescein angiography, we must first understand what is luminescence and what is fluorescence. So I hope the slide is visible again.
Yes.
Okay.
Manisha.
So luminescence basically means when there is light emission. When there is light emission that occurs when a substance is stimulated by electromagnetic radiation. While fluorescence is when this luminescence is maintained by a continuous excitation, we term it as fluorescence. And our entire fundus fluorescein angiography is based on the principle of fluorescence. And that's why it's important to understand. So let's understand what is sodium fluorescein. It's basically an orange-brown crystalline substance. It's triphenyl methane dye. It's a water-soluble dye. It fluoresces at normal blood pH. 20% of this is apparently free in bloodstream or free-flowing in bloodstream, so it doesn't get attached. Its absorption range is in the blue light range, which is between 465 to 490 nanometers, while it emits the light in the range, which is a higher range in the green light color range, which is 520 to 530 nanometers. So in the entire concept or the principle of fundus fluorescein angiography is based on this, where the sodium fluorescein dye molecules are going to be absorbing the light in the blue range, and they're going to be emitting the light in a higher range that is in the green range. So we have an excitation taking place in the blue range, and we have the emission which is going to be taking place in the green range. So the normal behavior of fluorescein in the eye is when we want to know which all structures in the eye it's going to be identifying or to help us identify. The choroidal vascular network apparently is freely permeable to sodium fluorescein. So if you don't have the sodium fluorescein staying on within the choroidal vascular network, we will not be able to image it. It's only those structures which are impermeable to the eye, such as the reticulature, or we have the RPE which are impermeable. We will be able to or we will be able to image the structure. So primarily this diagnostic procedure is meant where we would like to see the vasculature and the RPE. So this is just diagrammatic representation of the same thing. Here you have the choroidal vessel, what you are seeing. The dye has freely flown out of the choroidal vessel, so you are not able to see the structure. While these are the RPE cells, so RPE cells are impermeable to this dye and you are able to see it. And this is again the retinal vessels. Again, the dye is not able to go out of it, so you are able to see the retinal vessels.
Dr.
Now
Manisha,
this is a
Dr. Manisha, one second. There was some lag in this slide coming through. Can I request you to just repeat the whole thing again, the previous slide, not this slide, the one showing the RP and the blood BRB?
This one, sir?
Hold on, it goes very slowly. Yes, this one.
Okay.
Yeah. Can you repeat this slide? No. Yes, this slide.
This one?
Yeah, can you repeat this again, please?
Yeah. So sodium fluorescein dye, we have to understand that which structures it's going to help us image or understand what is the problem in which structures of the retina. So this is representing the choroidal vessel, and the choroidal vascular network is freely permeable to the sodium fluorescein dye. So the dye flows out of the choroidal vessel, and therefore we are not able to see the choroidal vessels very nicely. This is in contrast to the ICG dye, where the choroidal vascular network is impermeable to the ICG dye, and you are able to better delineate the choroidal vascular network on an ICG. While if you see the RPE cells, these are again impermeable to the sodium fluorescein dye, so you're able to see the RPE cells and their abnormalities on FFA. And this represents the retinal vessels, which are again impermeable to the sodium fluorescein dye. So you're able to again identify the various problems which are going on in the retinal vessels. So FFA in a nutshell is a good diagnostic procedure to understand the pathologies of RP and retina, but it is not a good procedure when you want to study the choroid and its abnormalities. So this is something which we need to keep in mind. Now this is going to be an animated way how the FFA works. So I'm going to move on extremely slowly because Saurabh sir has said that there is a lag time and I'll be conscious of that. So what you see over here is, this is the eye. This is representing the two filters what you have in the machinery, and this is the source of the light that is used. So what you basically have is you have the fluorescein dye, which is going to be injected intravenously. It is going to be reaching the eye and it is going to be spreading within the entire eye. And then what happens is that you are going to be emitting the blue light, which is the excitation light, which is going through the blue filter, which is the excitation filter, which will not allow any other range of the light to pass through it. So it's only the blue light which will pass through it. It's going to cause an excitation of the sodium fluorescein dye. And once these dye molecules, they get excited, they are going to emit the light in the higher range, which is going to be in the green range. So you have the green light coming out, and this is going to go through the barrier filter. The barrier filter is basically a green filter, which is going to allow only the green light to pass through it and not any other range of the light. So this is how you are going to be basically identifying the various structures inside the retina. So this is how it works. You have the blue light, and after excitation, you have the emission of the green light in the higher range. So I hope I'm clear on this. This is the basic principle of a fundus fluorescein angiography.
Dr. Manisha, just 1 second. For the postgraduates, if I understand correctly, this is something that once in a while, when you're going for the DNB exam and other exams, they do pass out a FFA printout to you and ask you how was this done. Sometimes they give you a bottle of the dye and say what are the concentration of this, how does one constitute the before doing the angiography, in how many ml do you mix, how much. So I was just going to ask Manisha, do you have any slides on the side effects of FA or contraindications?
Yes.
Do you have a slide?
I'll be covering all that in the coming slides, sir.
Right. I'll please carry on then.
So now these are two terminologies which are very commonly used, and we should all be aware of this. One is the pseudofluorescence and one is the autofluorescence. So what exactly is the pseudofluorescence? This is when the non-fluorescent light, that is the blue light, it is able to pass through the barrier filter. So in my previous slide, I explained that the barrier filter is basically the green filter, and it allows only the green light to pass through it and gets captured inside the camera, which we take as a photograph. But if there is a filter mismatch, or if your barrier filter has grown old, it's not able to filter out the other range of the light. You have some amount of blue light also passing through it, and this causes a pseudofluorescence. While autofluorescence is the emission of light in the yellow-green spectrum when illuminated by the blue light, even in the absence of the dye. So here autofluorescence would be that you have not injected any dye, but you're already seeing some amount of fluorescence happening. And this is something very common which can happen, like you have an optic nerve head drusen, which can have an autofluorescence. So you will be able to see fluorescence even before you've injected the dye. An astrocytic hematoma, again you can have a autofluorescence from the astrocytic hematoma, and you would feel surprised, how come I'm getting a fluorescence when I've not injected the dye? So these are the few of the pathologies where they fluoresce even before the injection of the dye. So we have to be aware of these two terminologies. Now let's understand what is the equipment involved when we do a fundus fluorescein angiography. So you have a fundus camera and you have the auxiliary equipment. You have the fluorescein dye, and this is going to be a 20% dye, which is going to be dissolved in 3 ml It comes in a 3 ml vial, and it is going to be dissolved in the solution, that is the injection, which is going to be used for injecting your fluorescein dye. So basically the injection which is available for any dissolution. And then you have the standard emergency equipment, because you have to understand this is an invasive procedure. So you have to be prepared to be dealing with any kind of an adverse reaction. Now, I think this is something extremely important. You cannot plunge into doing a fundus fluorescein angiography without taking an informed consent. And this is a medico-legal, it can create a medico-legal problem, because you may land up with very severe adverse reactions, because one needs to understand you are injecting a dye into a patient and his body may react adversely. The second problem is that there is no kind of an allergy test that you can do with this fluorescein dye. So there's something you have to be mentally prepared. So if you are dealing with a patient who's previously undergone an FFA without any problems, you can be comfortable that he's not going to react adversely. But if you are doing a fundus fluorescein angiography in a new patient who's never undergone this test, then you have to be a little more extra cautious. And informed consent, however, is taken before doing this particular procedure in every patient and every time. You have to also check that the pupils are well dilated. You must have all these things in place, like you must have the vial of the dye, you must have the scalp needle, you must have the syringes ready. Your fundus camera should be ready. So you should have already clicked your photographs, like the red free filter photograph, the color fundus photograph, and then only you should say, okay, everything is working fine and I can plunge into doing a fundus fluorescein angiography. You must sometimes also, some people who are not having a file number, it's a good idea to do an identification photograph, which will help you to know that this FFA belongs to which patient. You must check the patient positioning, that he is comfortable, because during the procedure, it may be a little difficult to change the position. And then, of course, a color photograph, you have to check out the focusing, what is the illumination that you are using. All that needs to be checked before you plunge into an FFA finally. So the first step is to do a red-free photograph, which is with the use of the green filter. This is an extremely important photograph. And like I think you had a discussion yesterday also, that when we are using an indirect ophthalmoscopy, you sometimes are using a blue filter and sometimes we use a green filter. And now we know that the green filter is extremely important for identifying pathologies or lesions, which are going to be like a microaneurysm, or like seeing the blood vessels, which are better delineated with a green filter. And if you are wanting to see the dye, sometimes the patient starts vomiting, is not very cooperative while sitting on the fundus camera, and you are losing time. You want to know where the leakage of the dye is taking place. So that is again another point where you can use your indirect with the blue filter on, and you would be able to identify where the leakage of the fluorescein dye is taking place inside the eye. So these are again certain more uses of your blue filter of the indirect, and the red free photograph I just mentioned why it is important before you go ahead and do your fundus fluorescein angiography. So to take a pre-injection photograph, and this will basically help you identify any kind of the autofluorescence that you are having, or any kind of the pseudofluorescence that you are having. Then you start injecting the dye, and simultaneously you start the timer. The first photograph in a young patient would be approximately, the dye will start appearing at about 8 seconds, while in elderly patients, the retina arm circulation time is approximately 12 seconds. So you have to be aware of this, and that's the time when you start taking your first photograph. And then after every 1 to 1.5 seconds, you keep clicking photographs, while the late phase photographs can go as late as 10 minutes or 15 minutes, and sometimes some people even prefer taking a snap as late as 20 minutes. So this is just a slide which shows you what is the normal circulation time. So if 0 is the time point when you've injected the dye, you have the dye reaching the posterior ciliary arteries at about 9 seconds. You will see the choroidal flush, which is also called the pre-arterial phase, at about 10 seconds. You have the retinal arterial stage at about 10 to 12 seconds. Then you have the capillary transition stage at about 13 seconds. You have the early venous phase at about 14 to 15 seconds. You have the venous stage and the late venous stage, which are going to be between 16 to 20 seconds. And then the late staining will take place at about 5 minutes. So this is important. And this is also important, especially when we are going to be comparing, if we are supposedly having a diagnosis of a central retinal artery occlusion, you would like to see that there is a delay in the retina and the arm circulation time. There may be a delay because of a CRO, and you have to compare it between the two eyes. So these time frames are extremely important, where we should be aware what are the normal time frames and when are we dealing with a delayed time frame in any special pathology that we are dealing with.
Dr. Manisha, just one question here. So you are saying that when I'm doing angiography for a patient, if I have pathology in one eye only, I should do the angiography for the other eye also?
Absolutely. I mean, you have to keep shifting the photographs. When we are taking the photographs, you have to keep clicking photographs of both the eyes simultaneously. In the sense, keep shifting from one eye to the other. So if you have a delay in the appearance of the dye in the one eye, which is probably having the pathology, you have to compare it with the normal appearance of the dye in the other eye. And that is the time when you will diagnose that, yes, there is a delay in the retina arm circulation time in a particular eye. So it's important. I think that's something important what Dr. Saurabh has highlighted, that you have to click photographs of both the eyes, even if you are dealing with the pathology in one eye.
Supposing I have a patient of, let us say, diabetic retinopathy, and I have one eye just small, I can see clinically microaneurysms, hard exudates, some macular edema, already seen on the OCT in one eye. But in the other eye, outside the arcade, I'm suspecting a neovascularization. Let's say right eye looks like just a CSME, left eye I'm query a PDR. I'm not sure how it is, what is it. So what if I'm doing angiography? Should I start which eye? Right eye has only CSME, left eye is query neovascularization. Which eye should I start with first, or does it matter?
So that is, no, it is absolutely an important thing. Here, clinically, you have diagnosed that there is a proliferative diabetic retinopathy in the left eye. So I'm not concerned about diagnosing. I've already made my clinical diagnosis. I am doing a fundus fluorescein angiography basically to rule out that is there any evidence of neovascularization in the right eye, which I was not able to identify clinically. So when I'm doing an FFA, my entire focus is going to be on the right eye, because I'm looking to identify any subtle neovascularization which I have missed on my clinical examination. So here I would specify to my technician that please start and focus more on the right eye, because the left eye is already, the diagnosis has been made and the plan of management accordingly. I hope I've answered your question, sir.
If I understand correctly, one eye I am reasonably sure it's NV, but maybe not sure. So even if I take one or two photographs over there, the NV will show up for sure where I've suspected it. Whereas a good eye where I've not seen anything clinically, you are telling me that the angiography will help me pick up the small NV if it is there. Do I understand correctly?
Yes, absolutely.
Okay. So I will stop here to ask you two questions. Dr. Anubhav had asked this question before, and I had taken a photo of that. But another questions I'm not really able to understand myself also. Why do FFA films, I'll repeat that again, Dr. Manisha. Why do FFA films and prints, there is a printout that you have on FFA film, appear black and white, in spite the emission is in the yellow-green range? I didn't understand that. So what he's saying is when you've got the green filter, yellow-green range, the emission is there. Why does it be black and white?
So the contrast is the maximum in the black and white photographs. When you are identifying any of the structures of the eye, when we are doing an OCT also, now earlier we used to all see the colored photographs of an OCT. But now we all prefer a black and white photograph of the OCT because the contrast is the highest in a black and white photograph. And that applies the same to an angiography also, that here also you want to capture the images in a black and white frame because the contrast of the images is going to be the maximum. Now
Okay.
let's move on
No,
to
no,
the
no, no.
various.
Manisha, sorry. We'll finish off the three questions over here.
Okay,
The
sorry.
questions, the chat box, the questions move up. Dr. Kapil has asked a specific question. Uh, if venous route cannot be assessed or accessed, I am assuming, then oral route of fluorescence can be performed. This is quick. Can it be performed? His
Yes.
question is that.
So Dr. Kapil, I will be just coming. I have a slide on oral fundus fluorescein angiography also. So I will be just telling you about that
Right.
in a short while.
There is a question from Dr. Priyanka. Why is skin test for hypersensitivity not done routine with FFA? I repeat the question. Why is skin sensitivity for hypersensitivity not done routinely with FFA?
Okay. So here, why we cannot do a skin hypersensitivity test with the fluorescein dye, because it's an extremely irritant dye. And if you're going to do an intradermal test, you can actually land up the patient in an anaphylactic reaction. The only way of ruling out that the patient may have a problem when you're doing it for the first time is that don't give a bolus of your dye. You have to do a slow injection. Your photographs may be a little not as high quality as you would expect because you've done a slow injection. The ideal way of doing it is as a bolus injection. But it has been seen that if, God forbid, the patient is to have any adverse reaction, with the slow injection, the adverse reaction is not going to be so much there. But you possibly cannot do an intradermal test because it's a highly irritant dye and it is best avoided.
I will make a small point over here, Dr. Priyanka. What Dr. Manisha said is absolutely right scientifically. I repeat myself again. What she has mentioned is absolutely right scientifically. As long as I was part of an institute, we never did skin hypersensitivity tests. I now do private practice to explain this to a lot of our patients that the skin hypersensitivity test is useless, is extremely difficult. It is also extremely difficult to explain to a lot of our physicians who are doctors, who are not ophthalmologists. Very few understand the importance of this. And if, God forbid, a patient has a problem systemically, a lot of poorly qualified people sitting on major panels and committees will ask this very wrong question of why was skin hypersensitivity not done. Because of these so-called bureaucratic political reasons, which I call, skin hypersensitivity is done a lot of places. But let me reassure you what Dr. Manisha said. I have seen, and all of us have seen, patient had a skin hypersensitivity test. Nothing happened at that time. And the moment you gave to start the DFA, patient had a major anaphylactic reaction or had some problem and fell down, vasovagal, whatever it was. So, to answer the question again, like Dr. Manisha said, a skin hypersensitivity test does not, a negative one does not rule out a patient having a problem, but politically, medical legally, wrong medical legal statement that I'm making again, it does help sometimes that yes, this was done. So as if you've been careful, but really scientific doesn't make any sense at all. Uh, Dr. Manisha, are you going to talk about serum creatinine levels in nephropathy and FA?
Not really, sir. I think I have mentioned it. Let me just run through the slides, and if we miss out on certain points, I'll be happy to,
We'll go back to that again. So let's leave this for now. This is again a big bogey for all of us. Patient with creatinine of 2.2, should I do angiography or not? What sugar level should I do angiography? This is an always and never-ending discussion question among patients, doctors, physicians, diabetologists. At what sugar level can I do an angiography? At what creatinine level can I do an angiography? Should I look at HbA1c? So we'll come to this point later on. Dr. Manish, I'm sorry to have disturbed you. Please go ahead.
Thank you, sir. So now let's understand what are the phases of a normal FFA, and this is again of extreme importance. We have one is the first phase is the pre-arterial or the choroidal phase. We have the arterial phase, the arteriovenous phase, the venous phase, and the recirculation phase. So these are going to be the various phases in which we have to read out the fundus fluorescein angiography. Now let's come to the pre-arterial or the choroidal phase. It's basically a segmental and a patchy watershed zone area. So you will see a kind of a patchy fluorescence. You will have a persistent filling defect. If it is there, then that means there is some pathology that you are dealing with. The visualization also depends on the RPE pigmentation. So in Indians, if the RPE pigmentation is high, this choroidal flush may not be very prominent. While in Caucasians, where the RPE pigmentation is not very high, you may actually identify the choroidal flush very distinctly. So it depends on that. And as we all know, the cilioretinal artery has its circulation, which is originating from the choroid. So you will see the cilioretinal artery also lit up during the choroidal phase. So that is important. So this is what is being shown in this diagram, where you have the cilioretinal artery, which has lit up in the choroidal phase.
One second. That, yeah. Yes. Yes.
So this is the depiction of the choroidal phase, where you have the choroidal flush. So you have this patchy hyperfluorescence. You also don't have any dye being identified within the retinal vessels. You see they are all empty vessels. You have the cilioretinal artery, which has lit up and is filled up with the dye, because as we all know, the circulation of the cilioretinal artery is originating from the choroid. And you are not seeing any other structure. So you have this patchy hyperfluorescence of the choroid and the cilioretinal artery in the choroidal phase or the prearterial phase. Now, what is the next phase? So you have the dye, which is going to go further on. So this is the arterial phase, the arteries which have filled up. And this is what is being depicted here, that the dye has now filled up the arteries. And this is the retinal arterial phase. So I hope my third slide is visible. So
yes,
now
yes.
you see, so this is the early venous phase. You have a laminar flow, which is happening in the veins. So this is the early venous phase. You have the dye now reaching the veins. So arteries are totally filled up. And now you have a laminar flow in the vein, depicting the early venous phase. And this is the late venous phase, where now you have all the arteries which have filled up and all the veins which have filled up. And this is going to be the late venous phase of the FFA that you are dealing with. And then the dye starts going back again into the choroid and going out. And this is going to be now the recirculation phase. So the entire thing has become dull. And what you're seeing is that the dye is going to be like a washout zone. And this is going to be basically the recirculation phase. Now, it is important for us to understand that on an FFA, how does the normal macula appear? So why does it appear like a dark zone, like a dark central zone? So basically here we have the xanthophyll pigment, which masks the background choroidal fluorescence. So ideally the choroid is also there at the macula. Then why are we not seeing the choroidal flush? This is basically because of the blockage of the choroidal fluorescence, and that is because of the presentation of the xanthophyll pigment, which is not allowing the choroidal flush to be seen in that area. Now, Dr. Saurabh has been teaching for the last 2 days what is foveola, what is fovea, what is the perifoveal area. So here also we have the perifoveal arcade, and this is going to be seen during the venous phase. And we have then the free anastomosis of the retinal capillaries, which is going to be around the macula. So this is important for us to understand that what is the kind of standing the macula.
Standing खड़े होके
So we have the
Dr. Manisha just wants.
क्यों सजा थोड़ी मिल रही है?
Dr. Manisha wants.
खड़े होके दर्द होते हैं पैर.
Can I just request everybody to mute their mics, please?
Yeah. Manisha, before you start, I will ask a question. I know a lot of you attended yesterday's and day for yesterday's. Because she said that angiography-wise also there is a different xanthophyll pigment here. The macula looks different over here. I will ask you, yesterday, we had said anatomically, not yesterday, for yesterday. On the first day, we had said anatomically there is a difference in the macula regarding the orientation of the layers of the retina. And which is why we have specific diseases and accumulation of fluid over there. We mentioned that over there. I want that some of you can very short in the message box write what you feel, or if you can answer the question as what are the difference in the anatomical structure of the retina and the macula. Charul, first इंटास वालों को तो कुछ देना पड़ेगा डॉक्टर चारुल को. हेड लेयर ऑब्लिक डॉक्टर अनुश्री, डॉक्टर चारुल, excellent. Dr. Priyanka, excellent. So top 3 names I have put on over there. Please, in task people take down these three names: Dr. Charul, Dr. Anushri, and Priyanka. So three far. The Manvi, you are there in the list for CME. I agree with you. But top three names, please take down: Dr. Charul, Dr. Anushri, and Priyanka. My request to doctor, all these three doctors, Dr. Charul, Anushri, and Priyanka, if you can in the message box indicate which medical college and which city you belong to, the INTAS people will want to, I hopefully congratulate you and maybe pass on a small gift to you. I hope so they do it. Charul, Anushri, and Priyanka. The three of you, please put your name of your college and which city you are in. Thank you. We'll go ahead, Manisha, with the question, with your presentation. Sorry for that commercial break.
That's okay, sir. Everybody needs a break. So now let's understand the normal optic disc. So in the choroidal phase, the deeper vessels are seen at the level of the lamina cribrosa. Two other capillary networks are identified. One is the epipapillary plexus and the radial peripapillary plexus. And in the late phase, you see the staining of the disc. So this is something for us to just, have it in our mind. Now, these are those various adverse reactions which Dr. Saurav was also just mentioning a few minutes back. So as far as mild is concerned, you can have a yellow staining of the skin or the urine. You can have a photosensitivity reaction. You can have nausea and vomiting, giddiness and paresthesia. These are mild. While you can have a severe allergic reaction in the form of urticaria, bronchospasm, angioedema, and an anaphylactic shock. Believe me, I myself, I've been into VR practice, and there have been occasions when we had to shift the patient to an ICU straight away after doing an FFA. So this is a procedure which is not to be taken lightly. And all the NABH accredited hospitals, when they come for an audit, they are very particular in checking out your zone where you are performing your fundus fluorescein angiography. Because the maximum problems that can happen in an eye hospital is the area where you are conducting an FFA. They check that whether you are having all your things in place to deal with any of the adverse reactions that may happen while you are conducting an FFA. So one has to not take this procedure lightly. And then, of course, one of the doctors just now asked, why can't you do an hypersensitivity reaction? So you can actually land up having a skin necrosis, lymphangitis, secondary to injection or the extravasation of this dye into your intradermal space or subdermal space. So you have to be extremely careful when you are handling this dye. So when you have extravasation of the dye, you have to check out whether there is the proper placement of your IV needle. You have to have a good illumination to identify. So what happens sometimes? You've placed your scalp vein, you dim out the lights of the room and you keep injecting the dye, and it is very late that you identify that there has been a displacement of your cannula or there has been a counter and all your dye has gone into the subdermal space. And that is too late because the patient will then have a severe pain and a reaction. So one has to be having some kind of a focused light over the arm of the patient to identify such a problem much earlier. You must have ice packs and antihistaminics ready to deal with such a problem. You have to also counsel the patient. He may come back running to you that I have an extremely yellow urine. So you have to tell them that there could be a discoloration of skin and urine. And this will last for about 24 hours till the entire dye is washed out of their body. And you can also have nausea and vomiting secondary to the dye injection. So what we tell our patients that you have to be nil oral at least for 2 hours before you have the FFA procedure. And this is basically to avoid the feeling of nausea and vomiting when you're going to be doing the procedure. Now, as far as the...
Manisha, one second. Yeah. This is exactly what I follow. This is exactly what we do. The only one point here is that in the last few years, have had a few physicians, doctors, who've had angiography. And I asked them specifically, you as a doctor, what is your advice? How did you feel? What is your thing? They said most of them, I wouldn't say all of them, most of them said, you must not downplay the fact that there is a nausea. He says, even if I didn't retch, my nausea factor was definitely there. The angiography was on, and it differs from person to person. And by far, all the physicians, all these doctors of whatever specialty, they all said, why do you say 2 hours of nil by mouth only 2 hours? Why did you make it more than that? like any other procedure. And then I said, no, we have lots of diabetics, we have lots of people. So he said, doesn't matter, make it 3 hours, 4 hours. I said, no, by the time you come and you get dilated, it's another 1 hour or so. The point I'm trying to make over here is that this is again anecdotal, that the physicians have explained to, this is my personal information, that they feel the nausea is far more than what whack karne se pehle they say we actually feel it a lot. And 2 hours, they have insisted that we should advise for more. I think this is just a take-home message. There is no hard and fast rule to this, but this is an experience that I've gained. I just shared that with all of you. Manisha, if there's any other point you want to make on this particular concept.
Sir, this is. I'll just make one point on this. Apart from asking whether if the patient has any allergy or any nephropathy or any kidney issue, this is one more thing we should ask, that did you ever get an FFA done earlier? And if so, did you have any nausea or any kind of a vomiting episode? This is something which you forget to ask. And if the patient says that, yes, I had nausea, you can prepare him beforehand with an antiemetic, or if it's not really required, you can just skip it. So this is one more history that we can always ask.
Absolutely. Believe me, any patient who's had a bad FFA once, before you ask them, they'll tell it to you. I had before and I had a bad time. No, I'm not getting it done again. It's the other way around. Normally, they will refuse outright. It's a very tough time. I'm not getting it done again. Do something else. Okay. Question for the fast singer first. Patient refuses to have an angiography. What test can you do? Patient refuses to have an angiography. Okay, we'll go ahead. Indications, we'll go ahead. Octa, Bilasha. Excellent.
No, sir, you can go ahead. That's an important question, what you've asked.
That's fast. Wow, very good. ICG, Manvi, no. ICG, we talk about ICG today. So Manvi Agarwal has mentioned ICG. And OST angio, Charul is always done without dye. That's a mistake you've made. And OST angio anyway does not have a dye. So the statement OST angio without dye is wrong. What you mean actually is that OST angiography can be done. I agree with you. All of you have mentioned Octa, OST angio, Priyanka, Zeel, Anubhav, everybody, congratulations. Good going. But on Dr. Manvi Agarwal, I don't agree with you. A fluorescent angiography cannot be replaced with an ICG angiography. Manisha, do you have any slides on ICG? Are you mentioning ICG?
No, sir, I'm not touching on ICG today.
So I will just quickly tell you, a fluorescent angiography is in a very generalized manner more for retinal pathology, and ICG will help you understand more the choroidal pathology. This is just a very generalized statement. So if you are looking for a fluorescent angiography finding, you cannot replace that with an ICG. Dr. Manvi, I appreciate your attempt, and I am happy you know about ICG, but mainly for polypoidal choroidal vasculopathies, for choroidal lesions, for RAP lesions, for those kind of things where we are looking, you're not sure what we're looking at. We do an angiography and ICG simultaneously in some of these patients, but ICG cannot replace an FA. That's all.
Sir, can I just add on to this? I would actually agree with Manvi to a certain extent that the patients who are having a problem of or a problem with fundus fluorescein angiography, they sometimes do pretty well with an ICG.
I agree.
As Dr. Saurabh is mentioning that yes, ICG is not very great test to identify retinal pathologies. It's better for a choroidal pathology. But if you are not left with any option, then ICG very much can be done in a patient who has a history of a problem with an FFA. Okay, so let's move on to the indications of fundus fluorescein angiography. So one would be that you want to make or you want to confirm any diagnosis. It could be any lesion that is present and you want to confirm how it behaves on an FFA, which will help you to confirm your diagnosis. Sometimes it could also be to assess the prognosis. For example, you are dealing with a retinal vascular disease, like you are dealing with a branch retinal vein occlusion. You want to see how this patient is going to fare in future. You want to see how is the macular perfusion. You can identify it very well on a fundus fluorescein angiography. Now, again, to identify or determine the need for treatment. So supposingly, I have a patient, like Dr. Saurabh was just mentioning a few minutes back, you have a patient of diabetic retinopathy, but you are not sure whether the patient is having proliferative diabetic retinopathy and is in need of a panretinal photocoagulation. You can again identify those lesions and take a decision for your treatment. Sometimes also it helps to monitor the progress of the disease. For example, you want to see how has been the effect of your treatment, like for a laser of CNVM, a medical treatment for CME. So you can actually monitor how has been the response to treatment. Now we had a question coming back a few minutes, which was on oral fundus fluorescein angiography. So again, this is something which can be done when there is an intolerance to IV fluorescein. And this is something very useful for small children where they will not be cooperative for getting an IV cannula fixed. So these are two indications where you can do an oral FFA. You can also very easily do it for simple macular pathologies like a CME, where you don't need extensive peripheral photographs, and it can be very well done with an oral FFA. So here you have 5 ml of 20% dye, and this is given, these are in the form of tablets, which are dissolved in the orange juice, and you can be given in the for the oral FFA. The concentration of the dye remains the same, but it is just that it comes in the form of tablets rather than a liquid. Or the other option is that you can, as was just being discussed, that if you don't want to do an FFA, then yes, you have other diagnostic modalities available. And then you have to hear the retina arms, the time, by the time when you take the oral dye and the dye will start appearing in the retina, it's much longer in comparison when you have injected the dye intravenously. So probably you'll have to wait for something like a 30 minutes before you start appreciating the dye in the retina. So here you have to patiently wait before you start clicking your first photograph. Now, this is an important segment of my presentation where we need to understand hyperfluorescence term and the hypofluorescence. And we also need to understand that what exactly are the various types of lesions which can cause hyperfluorescence. So let's see, hyperfluorescence can be caused by leakage across the blood-retinal barrier. It can be caused because of the pooling in fluid spaces, and it can be caused because of staining. So these are 3 things which can cause hyperfluorescence. So if you come to the inner retina, you have microaneurysms, you have retinal new vessels. If you have it in the outer area, then you could have the choroidal new vessels like a CNVM. When we talk of pooling in the fluid spaces, like you have a serous retinal detachment, so the dye collects within that space, like in a central serous retinopathy. You have any kind of a pigment epithelial detachment, which is again a potential space where your dye can collect. In cystoid macular edema, you have cystoid spaces within which the dye can collect. When we talk of staining, as I mentioned, there are certain structures which can autofluoresce, which is like the disc or the sclera. And you also have certain abnormal structures like the drusens, sometimes the scar tissue or the vessel walls, which can also undergo a staining. So one needs to be aware of these structures which can show hyperfluorescence. And we must know how to differentiate this kind of staining from an actual. The other thing which can cause a hyperfluorescence would be an increased transmission. And this is basically what is termed as a window defect when you have the loss of the RPE cells. And this could be again a normal where you have an hypopigmented RP, like I mentioned in Caucasians, while it can be abnormal when you have a RP atrophy setting in, like we have a geographic atrophy setting in the wet AMD patients or in the AMD patients. And in those patients where you have an atrophy of the RPE, you can actually have a window defect which may appear as hyperfluorescence, but we need to differentiate it from the hyperfluorescence secondary to the leakage. Now, this is again a diagrammatic representation of all those lesions. So this is like a normal fluorescence that you are seeing. Here you are seeing the hyperfluorescence, which is because of the incompetent retinal vessels. So this is because of the leakage of the dye from retinal vessels or retinal capillaries. This is the pooling of the dye which is taking place. So you have a pigment epithelial detachment and you have the collection of the dye underneath that. Here, the differentiation point would be that this will have very well defined borders, which are not going to be increasing in size over the time. And that if the size is going to remain the same and it is going to be of the same shape. So this is just that the dye has got collected within a closed space. Here you have the dye which is collected in the serous retinal detachment. So you like a central serous retinopathy. Again, it is a closed space within which the dye has collected. And here what you see is that there's a loss of the RPE cells because of the RPE atrophy secondary to a pathology or a disease. And that's why you are able to see more of the choroidal flushes seen through this RPE atrophy zone. And that is what is known as a window defect. So these are the various types of hyperfluorescence that a person can see.
Dr. Manisha?
Yes, sir.
Just to make it a little bit more interesting, previous slide, the nice representation. Yes. So normal is there right at the left. No.
Right. Okay, you want the next one, sir?
No, just the photograph that you had.
Okay. I'm having a problem in going ahead. Okay.
Now, what I was going to ask you was that color for that beautiful diagram that you had. It's come to us now. So don't change anything right now. So can you give us a clinical condition each while looking at this? You have said leftmost is normal, then hyper. You're talking about pooling. You're talking about all these things, RPA, whatever. So can you tell me one or two clinical conditions where this would fit in?
Yes. So normal is what we have already discussed. And when we come to incompetent retinal vessels or retinal edema, this is going to be something like a leakage from the retinal new vessels that you see in diabetic retinopathy. You can see neovascularization in venous occlusions. So you can have the leakage of the dye from retinal new vessels. You can also have the leakage of the dye from the retinal capillaries. So like you have in a diabetic macular edema, you see that there is a hyperfluorescence, a diffuse hyperfluorescence in the macular area that is secondary to the leakage from the retinal capillaries. While when you are moving on to the third one, you have a pigment epithelial detachment. You can find this in central serous retinopathy where you have serous pigment epithelial detachment. You can find it even in AMD where you can have serous pigment epithelial detachment. If this was a hemorrhagic PED, I would be presenting it in my hypofluorescence area, in my hypofluorescence slide.
I think that's perfect. Let's just name the diseases for the PG level. It's level. The first one, hyper, is PTR, CSME. The second one is CSR, and in some cases of serous ARMD.
Right.
That's what we have.
The last one, where you are seeing a window defect, is something like you have an RP atrophy, a geographic atrophy that you see in a dry ARMD. You can be seeing a window defect over there.
Absolutely correct. So we discussed the pathophysiology of it, and we also correlated some disease processes where we will see this over here. Right. Let's go ahead, please.
So now coming to hypofluorescence. So we have the masking of the normal dye transit, which is called the blocked fluorescence. And this could be secondary to media opacities. It could be because of secondary to accumulation of the pigment or because of something else. So if we have media opacities such as vitreous hemorrhage is there, you have very dense cataract or a very dense corneal opacity, you may not be able to capture the images very properly. And in that situation, the whole image may appear very dark and you may term it as a hypofluorescence where you're not able to get the normal fluorescence. Then you have the pigment accumulation, or you could have an accumulation. So you have the pigment or you have the accumulation of the blood. So you have the blood, which could be in the pre-retinal zone, or it could be in the intraretinal or the subretinal. So blood in any level, you will be getting a hypofluorescence, and this would primarily be because of the blockage of the underlying choroidal fluorescence, which you are not able to see. The third condition could be where you could have an abnormal pigment accumulation, which again is not going to allow the choroidal flush to be seen through. So these are all examples of blocked fluorescence. You have exudates also, edema and fluid, well, partially, but primarily it is going to be because of the upper three reasons. And the other reason for a hypofluorescence would be where the dye is not able to reach that area, and that is because of the capillary non-perfusion. So this could be because of the retinal vessel closure, or it could be because of the choroidal vessel closure. So this could be in conditions like you have a CRAO, where you again don't have the eye reaching the retinal arteries. You will be seeing that arteries itself, they are going to appear as dark and they are going to be hypofluorescent. So we have to be sure that the hyperfluorescence, is it because of the blocked fluorescence or is it because of the capillary non-perfusion? And how you're going to differentiate between these two types of the hypofluorescence? There lies the importance that you always have to compare your fundus fluorescein photograph with a color fundus photograph. And you have to then compare both and then take a decision. Am I seeing a blood accumulation there, which is blocking underlying choroidal fluorescence? Well, then yes, I'm dealing with a blocked fluorescence. While if I'm seeing that there is a gross hypoperfusion in that area because of which my dye is not reaching, I see no lesion in the color fundus photograph which could be causing a blockage, then yes, I'm dealing with a non-perfusion. So again, coming to a diagrammatic representation. So this is a normal fluorescence, what you are seeing over here. Here you have hypofluorescence.
One sec. Yeah, go ahead.
Okay, I always forget, sir, that there's a lag period between my seeing and you seeing. So on the left side, it is the normal fluorescence that you are seeing. In the second column, the hypofluorescence is because of the non-perfusion, because I cannot really depict it. But here you see that the dye has not reached the arteries or the veins. So there is a hypoperfusion. And the same is being depicted over here. Now here, as I was mentioning earlier, this is a pigment epithelial detachment. You have the blood accumulated under the RP, and this is causing a blockage of your fluorescence from the choroid. So this is again going to be causing a blocked hypofluorescence. You have blood accumulating in the subretinal space. And if I was to give you a clinical example, this would be very much as you see in a wet AMD case, where you can have the blood under the RPE, like a sub-RPE hemorrhage. You can have a subretinal hemorrhage, and this will result in a hypofluorescence. Then here you have a hypertrophy of the RPE. You see there's a doubling of the RPE layer, because of which there is more amount of pigmentation. And this in turn is causing a hypofluorescence, because through this choroidal flush is not able to be seen. And then last is the increased pigment in the choroid also, which can cause again a hypofluorescence. So these are some
Manisha, one sec. I think this is a very important slide. So I will repeat exactly what she has said. So I'll start off with the where she finished. No, let's go back. Yes, please. Thank you. So on top is written fluorescence, where the E ends. If you look at the E and look at the lowermost part of it in that column, where she has put those brown things over there, what she's showing there is the pathology is there, and there is the choroidal, whatever pathology, I'm not taking a name over there for disease, but that it is at that level. So you can have a block fluorescence over there also. Or if you come to the fluorescence, the N and the N same column down, you can see she has shown 2 layers of RP. So it's an RP hypertrophy over there. That is again another place where you can have a dye issue can happen over there. Then in the middlemost one where she has shown the blood, the red part, she has shown the red part below the RP and above the RP. I go back to yesterday, there was a nice question. I remember, I forget whose name it was. I'm sorry, the doctor had asked a very nice question, asking the question that clinically, this is what you're showing in angiography. Clinically, when we examine the fundus with the 70D or 90D, with the slit lamp microscopy, clinically, how would this look? Dr. Manisha?
Clinically, what will look, sir? I didn't get the question properly.
The blood under the RPE, sub-RPE blood and pre-RPE blood.
Right. So that is important to differentiate clinically. So if you have a blood in the subhyaloid space, that is between the vitreous and between the retina, it is going to be very often like a boat-shaped hemorrhage. It's going to be red in color. The subretinal hemorrhage or the subretinal hemorrhage that you see, again, it's going to be red in color. You have intraretinal hemorrhages, which I think Dr. Saurabh had also asked in his the first day. We have flame-shaped hemorrhages, and we have the dot-shaped hemorrhages. These are at the level of the retina before we go to the subretinal level. So the flame-shaped hemorrhages, they are, I think Dr. Saurabh had asked this question in that class, I remember, that they are at what level that they acquire that kind of a shape. So those are the more superficial, those are in the outer plexiform layer, they are more superficial hemorrhages. And the deeper hemorrhages are going to be the dot and the blot hemorrhages. Then you have the hemorrhage at the subretinal space, which is going to be again a red color hemorrhage. But if you were to differentiate that from a sub-RP, it's going to be a more dark colored. It's going to be having a more blackish hue attached to it. And that is how you will be able to differentiate that, yes, probably I'm dealing with an element of a sub-RPE hemorrhage.
I agree with you. This is the point I think this is the question was asked, that anything which is very dark, maroonish, blackish is sub-RPE. More redder, more fresh, more bright is prenatal heme. Okay, we'll move ahead. Thank you so much, Manisha.
Now, these are some of the ground rules which I have made, which I always highlight to my fellows. One is that never ever in your practice just start reading up a fundus fluorescein angiography. You must always have a color fundus photograph by the side of FFA frames, because it is based on comparison with your color fundus photograph that you are going to decide what kind of hyperfluorescence or hypofluorescence that you are dealing with. So it is going to be absolutely unacceptable where you start commenting on your FFA films without comparing it with a color fundus photograph. Then when you start reading out an FFA, it's important that you start which eye color fundus photograph or which eye FFA you are describing, and also start from describing the optic nerve head. Then you also have to, this is again the same point, that you have to correlate the findings of your FFA with the fundus photograph. And then you have to always see how that lesion behaves in your early, mid, and the late frames of the FFA, based on which you are going to decide, I am dealing with staining, I am dealing with pooling, I am dealing with a leakage. And this is going to be only based on how that lesion is going to behave throughout the FFA, and it cannot be based on just one frame that you are seeing. Now, this is very often where a lot of people in today's time, they keep asking whether we are having, can an OCT replace an FFA? So that's why I purposely put this slide there. So FFA basically gives a topographic view of the retina, helping in delineating the treatable lesions and macular ischemia, which possibly you can't see with a regular OCT, though on an OCT-A, you can make out these days some element of macular ischemia. While on an OCT, what you see are the changes in the internal structure of the retina is what you see, which is not seen in an FFA. As far as OCT is concerned, you are measuring the central macular thickness in a reproducible manner. So there you can do actually a quantitative measure. While you cannot do a quantitative measure on an FFA, you are not able to quantify it. The response to the treatment can be very well measured again on an OCT, but a quantitative measure of your response cannot be done on an FFA. Leakage is something very important. Leakage from a lesion can be very well seen on an FFA. This is something which we can never see on an OCT. And I'm sure Dr. Saurabh will agree with me. In a lesion like a myopic CNVM, where we keep saying that the signs of an active CNVM are presence of subretinal fluid, subretinal hemorrhage. Believe me, myopic CNVMs are the most deceptive looking CNVMs, where on an OCT, they may look as very subtle, they may look very inactive, but when you do a fundus fluorescein angiography, you may see a very gross leakage from these very benign looking CNVs, and that is what is going to make you decide that this is an active myopic CNVM, which apparently you would have missed diagnosing on just doing an OCT. So myopic CNVM is an important lesion which I wanted to highlight, where an FFA plays a crucial role in, taking a decision whether you are dealing with an active or an inactive CNVM, and when you want to stop the treatment and whether you want to continue with the treatment. So this is an example which I wanted to quote to highlight that any lesion where you want to see the leakage, I think an FFA is going to be indispensable.
Dr. Manisha, before you move ahead, So approximately how many more slides do you have?
Now I'm just showing some photographs of common retinal pathologies, sir. So I think about maybe 6 to 7 slides.
And do you have a CSR in that?
Yes.
Okay, because there's a question from Dr. Kapil which says how to differentiate PED and CSR on FA, and then he says both have pooling of dye. I repeat my question.
Okay.
He
So
says
I get your
CSR.
question, sir. Let me reach that slide where I'll show the photograph. I'll be able to explain Dr. Kapil well.
Yeah, what is pooling of dye and why? What is PED? We'll go at that. Leakage and pooling.
So let me go to my first pathology slide on an FFA. So I wish I could interact with all of you one-to-one, but what you see on a color fundus photograph is just a sclerosed vessel is what you are seeing. When you see your early frames, you see your mid frames, and you see your late frames, you see this whole network of vessels which is there in the supratemporal quadrant. You have these corkscrew kind of vessels which are present. You have a hypofluorescence in between. So whenever you are seeing an FFA, you see what are the areas of hypofluorescence that I'm seeing, what are the areas of hyperfluorescence I'm seeing, and then you try to clinically understand where could this hyper or hypofluorescence be originating from. So if I was to read this angiogram, I would say that, okay, I'm seeing these are the areas of hypofluorescence. And what are the areas of hyperfluorescence I'm seeing? Well, yes, there is a kind of a diffuse leakage which I'm seeing. And why do I call it a leakage? Because if you see that the margins of this hyperfluorescence are becoming blurred as you move on from mid to the late phases. The size has expanded. If you see the size of that leakage or hyperfluorescence, it has become much larger. The margins have become more blurred. And this is how I am going to identify that I'm dealing with an active leakage of the dye and not with a pooling or with a staining. So I again repeat, if there is going to be an increase in the size and if the margins are going to become blurred of hyperfluorescence, that means you are dealing with an active leakage. Now, if we were to talk of the hypofluorescence, what kind of hypofluorescence? Am I dealing with a blocked hypofluorescence or am I dealing with a hypofluorescence secondary to capillary non-perfusion? How I can differentiate? I'll compare it with my color photograph. I see no lesion over here. I see no hyperpigmentation. I see no blood, which could have blocked my choroidal flush in this area, but I still see a dark area. So probably this hypofluorescence is secondary to the capillary non-perfusion or a capillary dropout. So I hope I'm clear on this. So we have hypofluorescence, which is because of the capillary dropout, while we have hyperfluorescence because of the leakage from the retinal capillaries. And the diagnosis that I make is a supratemporal BRVO. So this is how I will be running through my other images, and I would be happy if Dr. Saurabh can even ask questions and we can get answers related to the images. Now this is another image that I am showing. So you have a color fundus photograph. So somebody asked that what kind of a hemorrhage. You are seeing a red color hemorrhage surrounding this lacy kind of a lesion over here.
Manisha, 1 minute. Can we make it interesting by, you have shown that, let me try and interpret what you are showing. So what I see in the left up photograph is a color photo of the left eye. I can see a red lesions in the center portion of the macula. They are sort of a C-shaped with inverted C-shape at the macula. I can see a whitish gray area at the center area of the macula, and therefore I assume there was some pathology in the macula in the left eye. I have done, and I'm now looking at the right upper part of the fluoroscintigraphy, and I can make out that some of the vessels are white, some of the vessels are black. So I'm assuming that this is an early phase, even though I have a severe complaint against all angiographies being done nowadays, where nobody puts a timing on top. And I think it's absolutely mandatory. We should go back to the good old days when having a timing on the top was an absolute necessity, which is not there in most of our printouts nowadays. So I can see in this one that there is some kind of the central area that we're talking about. The place which is red in my color photograph looks like that it is darkish black over there. And the central area which is grayish seems to have some whitish, exactly what you're showing over there. So I'm still not calling it any hyper or hypo. I'm just going to study that and go to my next angiography, which is the left lower one, where I can see that the whitish area has become much more, and my blood vessels have sort of become a little diffuse. It's not a very clear photograph. I'm not able to make out what exactly has happened, but to the blood vessels, retinal blood vessels, the supralateral branch vein or the inferior artery, whatever. But I can see the central area, the whitish area has become much more white. So I think the hyperfluorescence has definitely increased, and therefore I can see and I can see the blackish area has become more black. When I come to the right lowermost one, the blood vessels are definitely, I have gone to a much later phase over here, and I can again make out that the central area is sort of three sort of areas which are whitish, and definitely the superior to that and the other part, the temporal part of that lesion is more black in nature. Now in that black area, I can see sort of one blood vessel going on top of it. Can you show that with your pointer in the uppermost part? In that, yeah, in the right lower angiography photograph, on the place where the heme is there, there is a blood vessel going. Can you with your pointer show that?
Yes, sir. I'm showing it.
No, it has moved. Yes. So I'm now guessing, if I see this one only, that this is definitely not very anterior. It is more of a deeper layers because the blood vessel is going on top of it. So sometimes these are small hints. You have a poor photograph. Somebody sends you only 3 or 4 of them. I draw the whole angiography based on the color photo. And this, I have a central hyperfluorescence area. I have around that surrounding a hypofluorescent area. So I would say that that's probably a block fluorescence, and this is hyperfluorescence leaking from the lower layers of the retina, because initially it was there. And I'm probably looking at a CNVM is what I would like to say. Dr. Manisha, is my interpretation correct, or anything you would like to add to that?
Absolutely. Absolutely. Yes. One more tip I would like to give is that when you are running from your color fundus to the early, mid, and the late frames, follow each area of hyperfluorescence and hypofluorescence throughout the frames. So if I'm starting from this area where I know there is a hemorrhage, and you are seeing this area appear as dark, and Dr. Saurabh very rightly mentioned, you are seeing the blood vessels coming over it. Somebody, Dr. Kapil, I think, had previously asked, how do you differentiate between subretinal and sub-RPE? So sub-RPE and subretinal will appear the same, where you will see these retinal blood vessels coming over those hemorrhages. You will not be able to differentiate between the two. But if you had a pre-retinal hemorrhage, like you had a subhyaloid hemorrhage or a vitreous hemorrhage, then you would not have been able to see even the retinal vessels. So you can differentiate between a subretinal, sub-RPE and a subhyaloid hemorrhage. So the hyperfluorescent area remains more or less the same. And why it is going to be appearing a little different? Because you have an expanding area of the hyperfluorescence, which is secondary to the leakage of the dye from this active CNVM. So this is a very classic CNVM, which is typically described in textbooks as a lacy pattern. And you have, why do I say it's a leakage? Because you see that the margins are becoming blurred and the size is increasing. So you have an early hyperfluorescence, you have well delineated margins, but they become blurred and they become much larger in size. That's why we say that it is a leakage what we are dealing with.
Just to confuse the issue, Dr. Manisha, supposing I'm not so good at as good as retina, and that blood was very small. I'm not very appreciate. I couldn't make out the blood very well. Maybe a small dot over there. Why is this not a CSR?
It's not a CSR.
Yeah, why is it on a CSR leakage?
Which one, sir?
This particular patient.
Oh, okay. So let us, I think it will be a good idea if I show you the CSR. So in a CSR, what happens is you're going to be having I think let's see the CSR, sir, and then probably your question, we'll take it up.
Okay. I would also ask, there's an excellent question in the chat box. Dr. Aparna, I have a statement. There were the three things. First, I asked you all to put your name of college and city. 3 people, I forgot the names, and you all have not done that. But there's an excellent question from Dr. Aparna, which says, Madam, mostly disc appears hyperfluorescent in FA and darker in ICG. What is the reason? So we'll come back to this later on. You have to answer the question, Manisha. Please don't forget to answer the question. Hyperfluorescent disc in FA and darker in ICG. We'll answer that later on. Aparna will definitely answer your question, Dr. Aparna. Thank you. We'll go to the next slide.
So now this is another thing what we are dealing with. So what you're seeing over here is that you have the macular area over here. You are just seeing a dark area. And this is, I'm sure, again, I had explained how the normal macula looks over here. But you see that this is a little much larger than the foveal avascular zone that we typically see in a normal FFA. And in the middle phase, you have a kind of a stippled hyperfluorescence which is appearing. And then this hyperfluorescence increases further. So what is happening is that you are dealing with a hyperfluorescence, which is suddenly appearing. You don't know what is the source of this hyperfluorescence. It is in the central area. And what you're having is the leakage, which is happening from the choroidal vessels, is what you're getting. And this is very classically described in an occult CNVM, where you don't know what is the source of this particular leakage, which is happening. And it's originating from choroidal vessels, and it's described as late leakage of an undetermined source.
I have
now a disciform.
No, I have a complaint here. Go back. Anyway, I have a complaint here. There's no color photo.
Yes, I'm so happy
So
you raised that question.
So I will not interpret this as long as there's no color photo, there's no
Absolutely.
timing, there are no early phase. So I'm not commenting on this.
I will accept your objection.
It is probably a scar, and your fellow who does the thing, and if he has just hyper exposure zyada kar diya, and he says this is a CNVM which is active, I say no, this is a scar. So I will not accept this. I am confused on this. So
I take your objection. So we will skip this.
This is the point that Manisha was trying to make, that unless there is a color photograph, unless the timings are correct, unless you can see all the phases, the description that she made of the early phase, mid phase, venous phase, late phase, why is she hammering home all those things? Is to make a correct diagnosis. You need to have the color photo, you need to have red photograph, you need to see the other eye how it is, you need to go through each point specifically, and then only can you come to a diagnosis. Shall I will not venture into this one also. I know what this looks like. I'll let you do this. You written the diagnosis below, so we'll leave it at that. Manisha, please go ahead with this one.
So actually, I'd hidden these diagnoses. I don't know, my animation is not working. But what I had basically, if you see the color fundus photograph, now what you need to understand, you are seeing a circle over here, okay? So this circle, when you see through all the images, though it's not very distinct over here, if you find something like this throughout your images, you have to make a diagnosis that it's an artifact. Probably there is something on the lens, which is appearing exactly at the same place, and it is of the same size throughout your images. So please don't misinterpret it as a lesion. The second point I want to make again is that you see a hemorrhage over here, okay? Now this is a more dark colored hemorrhage what you are seeing in this particular photograph, though this photograph is not of a very good quality. And you again see a blocked fluorescence corresponding to this hemorrhage. Again, the retinal vessels, they are visible over it, but because of the appearance of this more darkish color hemorrhage, probably what we are dealing with is a sub-RPE hemorrhage. What we are seeing on a color fundus photograph is like a scar tissue over here. You are seeing hyperfluorescence over here. If you see, there is a minimal increase in the intensity of this hyperfluorescence in comparison between the mid and the late frames. It is not increasing in the size. The size is remaining the same. The intensity has very marginally increased. And that is why I am going to say that it is more of a staining what I'm dealing with and not an active leakage, because there is not, the margins have not become blurred. The size have not increased. What I see is just a minimal increase in the hyperfluorescence. Okay, so this is the type of the staining what you are going to be dealing with. So I have made a little quiz to make it a little more interesting. I think Dr. Saurabh,
Manisha, before we go ahead, I will request the INTAS people to make note of these three people over here. Dr. Priyanka, Dr. Charod and Arushri from Patna, Navsari and I missed that, Pune. The INTAS people must congratulate them. Even if you don't do anything, give them a book, do something. But please go to the departments and make sure that others know that they did a good job over here, the three of them, the three names that we had over here. Thank you so much.
Which college are they from?
One was Navsari, Gujarat, Pune, DY Patil, and Patna. One lady was there from Patna. Priyanka, Charul, and I've got the name again. Sorry. So before we go to quiz, Manisha, there's a question that we have.
Manvi.
Sorry, Manisha, one second. Good evening, madam. Excellent presentation. Very useful. My question: when I do a this is going ahead. I'm sorry. Somebody from the INTAS group, there was a nice question. It moves with the fundus camera. Is it to avoid the black shadow? Dr. Gopal from Vishaka Hospital, Visakhapatnam, had asked this question. The question has moved up. Can I ask Manish ji, can you just get back the question for me from Dr. Gopal, Vishaka Hospital, Visakhapatnam? That's one question which we have to get back to. I missed the question halfway through. Anubhav has asked, Dr. Anubhav has asked, ma'am, how to differentiate between staining and window defect? Are they the same? Staining and window defect. Dr. Manisha?
So as I mentioned earlier, that you cannot just do a spot diagnosis in an FFA. You have to always correlate what you are seeing clinically. So when I was to differentiate between a staining and between a window defect, I will always go back to my color fundus photograph, see what is the lesion I'm seeing. If I'm seeing an atrophy patch there is loss of RPE over that area in my color fundus photograph, I'm dealing with a window defect. While if I'm seeing a lesion which will take up the dye stain, which is like a scar tissue, like I just showed you, it is not going to be a window defect, then it is probably what you are dealing with is a staining. The other thing is going to be that, yeah.
Sorry. Dr. Anubhav, I think ma'am said very correctly. I'll make it even simpler. Both staining and window defect are both hyperfluorescence. Like she said, you have to see clinically what was there on the color photo, what is the diagnosis, and then go to the angiography. So a scar tissue which is there in the retinal tissue, where it takes up a dye minimally, it does not increase in size, it does not increase in hyperfluorescence too much, that will be a staining. And like she said, clinically you can see an RP atrophy, that will give a window defect. But mind you, like your question is, both are hyperfluorescence, but differentiating is not through angiography, is more through clinical and angiographic correlation. Sorry, Manisha, go ahead.
Okay, so I have put a few, interesting fundus fluorescein angiography images. And I'm sure, I hope I don't give the opportunity to Dr. Saurabh to complain that there's no color fundus photograph. So we do have a color fundus photograph over here. And how would you like to go about it, Dr. Saurabh? Do we ask somebody to identify or do you want me to describe it?
Okay, one second. This will go away again. Hold on, Manisha. This is again a second time Manisha has put in. This is from Dr. Venkat. Good evening. Excellent presentation, very useful. My question: when I do an FA, I sometimes get a shadow obscuring macular details. It moves with the fundus camera. Is there a trick to avoid the black shadow? Manisha, you understand this question? Gopal's question.
No, sir. Your voice was breaking, so I couldn't understand the whole question.
So when I do a FA, I sometimes get a shadow obscuring macular details.
Okay.
It moves with the fundus camera.
Okay.
So
is that a whistling you're dealing with?
Vice ring is a possibility. I would think more what you mentioned, artifact on the fundus camera itself is, I think, causing that for him once in a while.
But an artifact would usually remain fixed at one point. Whenever you're taking the images, your artifact will be at the same place in all your images. It's not going to really move around so much. But if while you are trying to focus and you see a black spot floating around, then probably there's something in the vitreous which is there, which you have to get it out of your field of view.
Yeah, I agree with you. So, prenatal hemorrhage, Okay, there is a question from Dr. Navya asking, ma'am, can you exactly tell us what is subhyaloid hemorrhage?
Okay, so subhyaloid hemorrhage or a pre-retinal hemorrhage are the same things. There are different terminologies for it. It's going to be a hemorrhage which is going to take place in the potential space between the vitreous and between your retina. And because it is a very a well demarcated space which is created by the separation of the vitreous from the retina, you often have the hemorrhage collecting in that space take up a boat shape, and that is what is known as a subhyaloid hemorrhage. Hyaloid is the term used for the vitreous. When it separates from the retina, there is a potential space called as the subhyaloid space.
So, Arpita Roy has muted herself again. Okay. So I'm guessing Arpita Roy is in Goa right now. Anyway, what is your quiz question here? Anybody wants to type an answer? So what is your diagnosis?
So I will just go ahead till the time other people are putting in their answers. Have a hemorrhage, which is obvious.
No, Manisha, there's a question there.
Okay.
Point to differentiate between CSR and central staining. And no, sorry. Want to differentiate between CSR and VKH on FA.
Okay. Unfortunately, won't be able to show a VKH over here, but if you were to see the FFA of a VKH, you are going to have multiple pinpoint leaks which are going to be spread out. They're not going to be just a few leaks that you see on a multifocal CSR. You may see 4 to 5 leaks. In a unifocal CSR, you may see 1 leak. In a VKH, you will see multiple pinpoint leaks which are going to be there throughout the area. They may be more concentrated on the macular area, but they can extend beyond the macular area also. And also there is going to be a pooling of the dye within the subretinal space or the subretinal serous detachment, which is going to be more or less the same as you see in a CSR or you see in a VKH. But believe me, sometimes even we as clinicians are a little confused between VKH and CSR. The two most important things where I would like to differentiate would be, you will see a hot disc. You will see a leakage from the optic nerve head, which is a sign of inflammation, which you will see in VKH, but the disc is not going to be hot in a CSR, again helping you to differentiate between the two. And if you do an OCT, again, there are classical differences between the OCT images of both these pathologies. But if you were to differentiate
Manisha,
on an FFA,
I know I'm being a little rude, but we are coming to the end of the presentation, so keep your answers much shorter. And we've had some answers to your question, your quiz here. Somebody's mentioned CNVM with the subretinal hemorrhage. Would you pass that as a PG level answer?
I would pass that to a certain extent. Yes, I would pass that to a certain extent. Yes.
Would you want to do an ICG in this patient?
Yeah, but the exact diagnosis would be an IPCV, and that is also a variant of AMD, so I will give that to you.
Right. So ICG is a possibility to do over here, ICG?
Yes, ICG is going to be very much helpful in this pathology.
Yeah.
Now let's move on to the next FFA image, and this is what you see over here. You have this hyperfluorescence, which is right over the area or in the perifoveal area. This is a hyperfluorescence, which is petaloid shaped. If you see, these are like a petals of a flower, which is surrounding this area.
I will stop there. Manisha, I'll stop you there. The PGs are fantastic. They've already answered CAB. We discussed this yesterday. So you've done a good photograph. We have lots of answers. Manish, Manvi, Priyanka, Abhilasha, Aparna, Donna, everybody's answered your questions. So we have we are doing a good job. You and me are doing a good job. Pooja and Sati are doing a good job.
So let's
hold on. They'll answer your question. Don't even bother to show what it is there.
I'm just keeping quiet. I'm keeping quiet because I have a dry mouth now.
Yeah. So PDR, somebody's mentioned PDR. I accept that. NVD, somebody's mentioned that. Rupali's mentioned NVD. So I accept that. Can we go next quiz question if you have any more? Upper has mentioned PDR. So here again, so I will just make a quick point over here. This is a slide in the right side, which corresponds to the hemorrhage over there, which is a blocked fluorescence.
Yes.
And we can see all these multiple neovascularizations over there. So the hyperfluorescence over there. And far temporally in the right eye over here, this is the right eye. There are some capillary non-perfusion over there. And there is some leaks for the microaneurysms also over there. So the multiple types of hyperfluorescence over here, for the microaneurysms from the NVE, both of them, and block fluorescence from the prenatal hemorrhages also. So this is the case of PDR.
I basically put up this image for anybody to differentiate. This is that if somebody says, why is this a pre-retinal hemorrhage and not a subretinal? Because here the retinal vessels, they are also blocked underneath this hypofluorescence. That is why this hemorrhage is much above the lesion or much above the retinal surface area.
And what about the disappearance?
What
She
about
hasn't
the?
shown the disc appearance.
It's not be clearly seen over here, but there is a leakage because you have a frank prolif over the optic nerve head. So there would be leakage.
I disagree. I will not comment on that. I will not comment on any disc on seeing only one FA photograph. I will ask for at least 4 to 6 of them.
That's exactly what I said, sir, that it is very difficult to comment on the disc just on one image. So you will not be able to really comment, but seeing to the color fundus photograph, you can predict what the image is going to be like.
There is a question which Dr. Manvi has written again, and I'm sorry I missed it the first time. Ma'am, what is the percentage of dye which is preferred? I think you said 20%?
20%, yes.
And why? I myself don't know why. Why is it 20%?
So 20% dye, you have the dye available as 10% also, you have it as 20% also, you have it as 30% also, but 20% is a good combination where the risk of the adverse reactions is going to be minimal and it's not going to compromise the quality of the images that you are getting. If you use a 10%, the adverse reactions are lesser, but the quality is much poorer.
Right. Now, we will come back to, I think, Dr. Kapil or Anubhav had asked this question regarding this PED leakage and pooling and CSR leakage pooling. So I will now point out over here what we have. What you have shown over here is in the right, on the color photo, I really can't make out much over there. In the right one over here, the upper one you have shown, there is a small hyperfluorescence in the upper part of the macular area. And that I'm not talking about the temporal part of it. I'm not talking about. I leave the temporal part of it. I'm just about what you point that this I'm leaving out. That single point over there in the consecutive lower 3 ones becomes larger in size and more brighter in size and more brighter. So for the pinpoint one
and
diffuse. So now this, and what would a PED look like over here if I had a PED also? A simple serous PED?
So this is actually a PED. This is a PED what you are having over here.
Yeah. Because the PED size is not increasing, it's remaining the same over the all 4.
Yes.
So to answer your question over there, Dr. Kapil or Dr. Anu, I don't remember which one of you, asked a very important question. This is a slide, this is not a slide, the slide, which shows the leakage, hyperfluorescent leakage in case of, which is CSR, which is the upper pinpoint one, and the PED is pooling of the dye, which is not increasing in size. PED is localized one area. It's stuck in one place. The dye accumulates there and stays there. That eye size does not increase. Whereas in a leakage.
And another pooling that we are seeing over here is of the serous detachment. What you are seeing. So you have, if you were to see a 3-dimensional image, you could make out that there is a fluid in this area. And what you're seeing again is. Okay, sir. Okay.
I don't confuse that. So I think we'll have to finish up very quickly. Aparna has asked a question again, Dr. Aparna. I'm sorry. We'll answer your question right now. Dr. Manisha will answer your question. Why does the disc appear hyperfluorescent in FA and darker in ICG?
I think Dr. Saurabh, I want you to answer this question.
No. The reason being, what is this slide over here? Okay, in the meantime, what is this one? This is a new one. ICG fluorescence.
So let
So
me
we have a
just
question.
quickly finish off.
Sorry,
Finish off this presentation quickly, sir. So we have CSR. This is a smokestack appearance, what you are seeing over here. So you are going to be having a pinpoint leak here. And again, you have a leakage and you have the pulling of a little bit of the dye within the cirrus detachment. This is an example of a multifocal CSR where you are having these multiple leaks which are seen. Again, these are the multiple leaks that we are seeing. Now, this is a diagnosis, Stargardt's disease, where you have these multiple, fishtail-like lesions, hard exudates, or you can say yellowish lesions, which are there in the macular area on the temporal side, also known as fundus flavimaculatus. I'm going to show my FFA of this particular fundus photograph, and I would be very happy if somebody tells me what is the classical finding on a fundus fluorescein angiography in a Stargardt's disease. And this is my last slide.
I think we've run out of time.
Silent correct.
Silent
Yes.
correct.
Yeah, excellent. Very good answer.
But as Snehanka said that we have two questions we will take up in tomorrow's session. What is the reason of smokestack appearance? Venkat has asked that, and we have the unanswered question of Manvi's answer, silent correct. The DFA and ICG thing. I think we'll take it up in tomorrow's class. Any other, sir, how to access this class? Who missed it? Dr. Aditya, please at the Mr. Manish, can you please, how to access class, who missed it? Can you post over here again the YouTube links for today and tomorrow, yesterday's ones? Dr. Aditya, they will be posting the links.
We will put up the links.
Now, Manish, please repeat yourself again, Manish, sir.
Yes, sir. We will put up the YouTube link for day 1 and day 2 session again. And for today's session, we'll put the link for tomorrow, sir.
Yeah.
We will have every day wise and the links for YouTube. And the people, they can view the sessions at their convenience.
Right.
Thank you, sir.
I'm in the process of sending all these YouTube links to everybody who is requesting for it, and you can write to me on eyesinha@gmail.com, eyesinha@gmail.com, and I will email you the YouTube link. The email is eyesinha@gmail.com. Go ahead.
I'm done. I have another webinar to go to right now. I leave immediately. I have another webinar. I have already supposed to participate there. Thank you, everybody.
I would like to thank Dr. Manisha Agarwal for the amazing presentation. I think everybody is going to save this